everything about tongue tie and lip tie and all of the problems that problem can cause next on this episode of All Things Women's Health. I'm a husband, I'm a father, I'm an obstetrician gynecologist of more than 30 years, I'm a small business owner, I'm a Catholic, I'm a lot of things. But right now, I'm your host as we talk about really all things women's health. From menstrual problems to migraines, mammograms to menopause, it doesn't matter. If it affects women and their health, it's on our agenda. And our agenda for this episode is, as I mentioned, tongue tie and lip tie in infants. I don't know of a problem that causes more angst, more anxiety, more frustration, more fear in the hearts of new parents than this topic. And it can be difficult, if not impossible, to get really good, trustworthy information on the topic. So I'm joined today by an expert in the field, Dr. Aaron Light. Aaron, welcome to All Things Women's Health.
Well, thank you so much for having me. I'm looking forward to having a nice conversation and at the bare minimum, helping some moms that might need a little bit of direction.
That would offer a great deal. I don't know why this topic is so difficult. I'm sure we'll explore that, but I would say in my world, at least once a day, I see a new mom with a new baby, or I hear of the story of a new mom and a new baby, and they're struggling. And they're struggling for lots of reasons, not the least of which they don't seem to be able to get trustworthy and good information.
Yeah, it's an interesting field to say the least because there's so much angst between pediatricians, dentists, tongue tie specialists,
lactation
consultants, and everybody has a different opinion on it.
It sure does.
Not everybody's opinion's wrong. Everybody's opinion is right. So I try to do my best to navigate that field with parents.
Well, now let's start with you. You're a dentist. Walk us through your journey to being an expert in tongue tie, lip tie.
Yeah. So I've been a dentist now 8 or 9 years. Started out as general dentistry. And shockingly enough, about, a couple of months into my practice, I actually got a chance to go to a continuing education course that was solely dedicated to pediatric airway. All right. And how dentists can apply things to that side of things. And I thought it was really, really interesting. But I was so early on in my practice that it just wasn't going to go for me. All right. Now we're going to flash back to while I was in dental school. We had our first baby. All right. My wife did a wonderful job. You actually helped with all of this process. And we had our first little girl at DuPont Hospital. All right. It was a little bit of a rough birth. We had to use Pitocin and really get things moving. She was about 2 weeks late. All right. But she came out healthy, doing really, really well. And almost immediately, my wife was struggling. She
With
just
breastfeeding.
could not feed.
Oh,
all right.
right.
She thought she knew what to do, and we just chalked it up to, hey, we don't really know. All right. Then your wife actually was the first person to mention it to us and said, yeah, I think she has a tongue tie. All right. Yeah, you should go maybe get that checked out. And at that point, I was so broke that we could barely afford to have a baby, let alone go get a tongue tie fixed or anything like that. So we kind of put it off. And my wife kept getting repeated mastitis, bleeding, nipple trauma, everything like that. And I'll kind of go over all the signs to look for as we go through this. But she was miserable. Finally, because at that time we were in Indianapolis, we found a chiropractor who was working with my wife and with my daughter. And the chiropractor said, oh, yeah, you need to get this fixed. Go see Dr. Newman. All right. So Dr. Newman is a dentist in Indianapolis that has been doing tongue ties for many, many, many years now. And we are still unsure. I was dentist in dental school. You know how much we learned about tongue ties? Nothing.
About as much as I did in school, probably.
Exactly, yeah. So we went over to Dr. Newman, and we get in there, and there's moms everywhere, babies crying and everything like that. And we go into the consultation room, and he lays my daughter down on the lap with my wife kind of across from him and takes a look, and he's like, oh, yeah, she has a lip and a tongue tie. All right. And he showed us kind of what we were looking for, and like, okay, all right. We still don't really know. Okay. But I was a dentist at the time, so I was like, can I watch? And he's like, yeah, sure. Go ahead. So they put these little goggles on my daughter and they strap her in and everything like that. And he takes his laser and does an incision under the tongue, does it a couple times, then does the lip and says, okay, we're all done. and we get the room afterwards. And my wife goes to put her to the breast, and instant, all right, pain gone, okay, and no pain from that point forward. All right.
That's amazing.
Baby number 2 comes along a couple of years after that, and we get that done very fast. All right. Dr. Newman does it like in the first week.
But did you leave that event thinking, I'm going to incorporate tongue
Not
in
even
my
close.
practice?
No. So then I graduate dental school, and then I start that process where I go to continue education. I was really interested in airway, but I was in a group practice at the time, and I still am. And they were like, hey, you need to focus on general dentistry. Get good at that.
Yeah.
Okay. I was like, all right, that's fine. Over the years, I just kept reading stuff and really getting into it and taking a lot of continuing education courses. And finally, I was like, I want to do sleep and airway. All right. That's what I do. And I actually brought one of my hygienists over with me to do this kind of stuff. And she's a myofunctional therapist. Her name is Jill. And she kept poking me to do tongue ties.
As part of that work.
As hard as that work. She's
I see.
like, I can't do my myofunctional therapy unless you do this. All right. Finally, I took a continuing education course taught by a gentleman by the name of Dr. Zaki. He's kind of the go-to ENT tongue tie expert in the nation. All right. He's out of Stanford. He does a ton of research. He does a great job. And after that course, I was like, yeah, I can do this. This isn't too hard. And that's when we started. And we saw our first patient, and now we see about 2 or so a day as we go through all of this. So it was a different journey, and really it was probably my hygienist that finally got me to do it.
It is sort of ironical, though, in retrospect, that you had that experience with your own child.
Yeah.
As a dental student, of all things.
Yeah.
Yeah. Did you and do other dentists think of this as a dental thing, for lack of a better way to say that?
So it's tough. So I'm in a group practice. Like I said, my group practice is called Summit Dental Group. And the other people in my practice, they never heard of tongue ties or lip ties or anything like that.
Right.
Okay. I've had to kind of teach them what to look for.
Yeah.
All right. Like I said, in dental school, they don't teach you anything about tethered oral tissues or what to do with them or anything like that.
Right.
So no, it was, dentists don't really know unless they get into it. And usually you're talking dentists that are at the very least more on the integrative, holistic, biological, that kind of whole health kind of time frame. So,
right.
Yeah.
It is fascinating because so you've got ENT, ear, nose, and throat specialists, otolaryngologists, pediatricians, I guess to some degree people like me, obstetricians, lots of other kind of birth workers, be it doulas, nurse midwives, and others, pediatric dentists. There's all of these people, but yet nobody seems to really want to own the topic as a whole across the spectrum.
Yeah.
Which is probably part of the frustration, I guess.
Yeah.
But I mean, in our own journey, it has been challenging. Several of my grandchildren have had tongue and lip ties and got better afterwards. But I've had, as an obstetrician, that same aha that you had. I can't think of how many times when I've seen a mom say, just like your wife, something is wrong, I'm dying. This wasn't so painful with my first child. I don't think it's supposed to be like this. We look, it's tethered, we reduce it, and she gets that look on her face with the first latch. And you think, I'm a firm believer of placebo, but I don't think that's placebo.
Yeah.
I mean, pain is pain.
Yeah.
She was having it, and suddenly now she's not.
Yeah.
Wow.
Yeah, it's fun because obviously it's not that much fun hurting these little babies. Doing what we have to do. They don't like any of it.
Of course.
Right?
Yeah.
But just seeing the almost instant change, and that's probably, and I'm just anecdotally saying this, but it's probably 95% of patients where it's almost instant that the mom's like, oh my goodness. And for the baby themselves, the differences between before and after are incredible. They go from these colicky kind of spit up, really gassy, really struggling, even some failure to thrive.
I was going to ask you if that
just
long
going
story
on.
with your daughter, had she had weight gain issues? Or,
She didn't, because my wife kind of bore through it.
Oh, right.
She's like, we're going to do this, all right? Because she really didn't want to bottle feed, okay? Because her and I at that point in our lives were really getting into whole health and how important breastfeeding truly is for development.
But it's not an uncommon part of the story.
No.
Yeah.
Yeah.
That's amazing. Well, we should probably move, I guess, from that fascinating history of yours into maybe a little more understanding and sharing of information for viewers about what is this tongue tie, lip tie thing that we're talking about?
Sure.
And then kind of go through some of the mechanics and repairs and all of those kind of things.
Yeah. Well, I did bring a few slides, so we'll
good.
kind of start through this a little bit.
Excellent.
So first big thing I need your audience to kind of know is there's differences between tongue ties and lip ties and buckle ties.
Not
and
all
of
created
these
equally.
things.
Yeah.
No. And some I absolutely have to do, some I do not. All right. Some you can see them from a mile away. Some you can't tell until you put your fingers in there.
Yeah.
Okay. So when I categorize this stuff, I usually categorize it more based on ages. All right. So as you can see on my slide here, frenectomies are considered infants. All right. And typically I will only do those up until about 6 months. All right. Frenotomies or frenuloplasties, all right, that's more older, all right?
Probably the same procedure for the most part, but different anatomy, different age child.
It is, and it takes longer. The older they are, the longer it takes. The more aggressive I can be with it, all right? With the infants, I'm not actually trying to be very aggressive, okay? So let's see here.
But before you leave that picture,
Yeah.
I mean, if you could go back and maybe just sort of walk through what you're seeing in each of those 4 examples.
So one of the biggest troubles that I think a lot of people have when it comes to tongue ties, especially practitioners, are there's a plethora of different ways of diagnosing it.
Yeah.
All right. They have all these different scales. 1 through 4 is it a posterior, is it an anterior, all of those kind of things.
Yeah.
And moms are confused. All right. So when I evaluate these children, I actually have the baby lay in my hands and I put my fingers in their mouth and I'm feeling for tension. All right. I tell moms and dads, I don't typically really care all that much about what it looks like. All right. I care more about how it functions. Okay. So you guys can see on the screen here, these would be considered class 4 anterior, really bad tongue ties.
Worst of the worst.
Okay.
Yeah.
Shockingly enough, these don't always cause issues. All right. Because if the middle of the tongue can still function normally, doesn't really matter how tight it is on the tip of the tongue.
Yeah.
Okay. But these are the ones that your standard everyday pediatrician is going to send to me. Okay. I get a lot of these. Okay. Now, as you can kind of see the lip tie up there, so that's a little bit of a controversial one too.
Yeah.
All right. And I explain lip ties to parents kind of like a suction cup. All right. So if the baby's mouth is a suction cup, it'd be like having the top of the suction cup curled under. Okay.
I think this is the example where moms will, when we ask, they'll say the baby's upper lip at feeding doesn't flange open, that it rolls around.
Exactly.
And they feel like the baby is gnawing on them. Yeah.
Exactly.
So
Yeah.
it's a dysfunctional suck.
Yeah, and moms can pick these up, and if you ever have a little baby who is really, really tight up here, all right, that's almost always an indication that that's going on.
I see.
Okay, but you guys can kind of see by the pictures. Typically, the lip tie, those are pretty obvious if you just lift the lift up and see that little bit of tissue that goes all the way under the ridge there. Sometimes you have this little cleft that kind of goes up. That indicates that tissue goes all the way up and under. And then I just ask the mom or the dad, what happens to the lip when you feed? Okay.
Does it flange open?
Does it flange open or does it curl under? And when I do this, I always have the mom right across from me. All right, she's holding the bottom half of the baby. I have the head, and the dad's usually sitting right next to me. All right, and I'm showing them this while I do it. Okay, so I'll go in and I'll pull up on that lip, and I'll say, "Do you see the whiteness that's showing up right here?"
Because it's under tension.
Because it's under tension. All right, and then I'll go under the tongue and I'll pull up. Do you see how this tongue will not move? All right, it's just not moving the way we want it to.
Yeah.
Okay. So I try to get the parents as much involved in what I'm doing as possible.
You know, I'm dying to ask you as a dentist because I hear it both ways, but that classic lip tie, is there an association with that and the space between adult teeth?
Yeah.
You know,
Yes, there is.
Is that truth or myth?
So we don't really worry about it until they get to 6 or 7.
Yeah.
All right. Because you actually want space in baby teeth. Like you want all of the baby teeth to actually not be touching each other.
Yeah.
Okay. So having something like that in there is fine. Now, when you get to the adult teeth and you have a big gap in there, it's actually pretty rare that I actually have to cut it. Usually orthodontics can bring it together.
Bring those together.
All right. I do have to sometimes. Okay. And frankly, when a kid's about 7 or 8, it's a really, really easy procedure at that point.
And repairing that in an infant, is that going to prevent the need to repair it in an older child?
Usually, if mom and dad do the stretches and things like
Which
that.
I'm sure we'll get to.
Yes. Usually.
Yeah.
You could, and I mentioned this to you earlier. When I'm doing this kind of stuff, especially on these little ones who just came out of birth trauma, who are already really, really tight and tense.
Yeah.
I'm trying to do as little more trauma as I can to them.
Of course.
Okay.
Yeah.
So I tell mom and dad, like, I take the laser and I use a CO2 laser to do all of this. All right. And all I'm really trying to do is, if you can see the screen there, I'm just trying to make an initial incision with that. And then I'll put my fingers with a little cotton gauze under it and I will push,
Yeah.
all right, until I kind of feel that release happen, okay?
Sure.
Yeah, the tissue's opening up under there, all right? And I do the same thing with the lip. It's more about tension release, okay?
Yeah.
And that avoids the biggest problem with these complications is getting into muscle tissue, all right?
Too aggressive.
Too aggressive muscle tissue, then it scars really bad,
I see.
all right? And those are the ones where they come back and like, it's way worse than it ever was. And my nephew's a good example of this.
Yeah.
All right. He was one that he's 10 or 11 now, but he had one done. Born, they clipped it right away and sent my sister home. All right. They didn't tell her anything about it or anything like that. So she didn't do any stretches. Okay. Then at about 3 or 4 years old, he had it done again, all right, because it tied back down so bad, all right? Again, no stretches, no myofunctional therapy, no muscle function therapy at all before or after. It shockingly scarred right back down, okay? And then I had to do it for a third time when he was about 9, all right? And I made him do a lot of functional therapy beforehand and a lot afterwards to get rid of the tension. But it was cutting through scar tissue, you know, at that point. So that's why if anybody ever comes and see me, you'll hear me say many, many times, I can do the best surgery in the world, but if the aftercare is not there, it doesn't really matter.
Wow. That sounds like orthopedics almost.
Yeah.
Those are great pictures. Yeah, thanks for sharing those, because I think those are pretty recognizable.
Those are the obvious ones. Yeah, and I was telling you earlier, that picture on the top right up there, that's one of my first adult tongue ties I ever had to do. And that kind of tongue tie, if you wait till you get to that age and have to do it, you're going to have 2 surgeries.
Oh, sure.
Right? You can't cut all of that in one, or you're going to end up hitting some things you don't want to hit.
Oh, I could imagine. Okay.
Yeah.
Oh, good. So thanks for that. Yeah, great examples.
Yeah. So, no, it's I really enjoy what I do, and I really enjoy helping out moms.
Yeah.
You know, it's especially because of what my wife went through.
Yeah.
And you know, when it comes to lactation and pediatricians and dentists, I mean, I wish there was agreement.
Yeah.
There just isn't. So I rely on the mom. And you mentioned it earlier.
Yeah, the questions the examples we brought up have all been breastfeeding problems. But, a question I've always had is sort of, is there a problem if there isn't a problem? Meaning, yes, I look and I see what looks like that. And I turn to the mom and say, are you having any latching issues? And she says, no, it's fine. Mm-hmm. So is that a problem simply because it exists, or is it a problem because there's a functional issue?
Yeah.
Functional issue in an infant is going to be feeding, I presume.
Yeah.
How do you work through that question?
So it almost always comes with follow-up questions, all right? So there are some incredible moms that I'm pretty sure just don't feel pain, okay? Because I've had some that have the most unbelievable tongue tie, and the mom's like, I feel fine, all right? Usually it's a mom that's had 4 or 5 kids, okay? And they don't know, but they say there's something wrong. Like with the infant, what I tend to see on these kind of cases is you're going to get gassiness like crazy, all right? You're going to get spit up issues. They call it a clicking sound, all right?
I hear that all the time.
They'll come on and off the breast, okay? You'll get a lot of kind of colicky issues. You can even get some like neck tension issues and things like that.
Yeah.
And it's really cool to just kind of see that stuff melt away.
So just because the baby's not losing weight and the mom's not in horrible pain doesn't mean that there's a functional defect, so to speak.
Yeah.
Speak a little bit about, I guess I would say, the role of the tongue in effective breastfeeding.
Sure.
Because I think most people think, and we talked about this with Hallie Greider when she was on talking about breastfeeding.
Yeah.
It's not all suction.
No.
Yeah. Talk about how that works.
No, and I have to tell you guys, I'm not an expert in breastfeeding, all right? I kind of make it mandatory that every mom that I work with at least works with a lactation consultant, all right? They are the experts. I'm not the expert. I get to know a lot about it, but I'm not an expert. So I explain this to mom and dad pretty simply, all right? I say the tongue, it kind of functions like a wave in the ocean, okay? So as the baby is trying to breastfeed, the tongue kind of goes out, curls up, and pulls back, all right? And it's actually trying to compress the nipple or the bottle or whatever you're using against the roof of the mouth and pull everything backwards, okay? So a tongue tie, all right, whether you have one like that, which would be an anterior, makes it so the tongue can't really go out.
It's got to
all
have
right?
mobility
It's
to do
got to have
that.
mobility.
Yeah.
And if it's tied in what a lot of people call a posterior tongue tie, it means it can't go up. Okay. Now, in my world, when it comes to sleep and TMJ and all the things that I do on the other side of my practice, I actually care way more about it going up than I do going out.
Really?
All right. And we'll talk more about that as we get through this.
Sure.
But the tongue is incredibly important on facial development. All right. Making the face big enough for all of the teeth and the nose big enough so that you don't end up with some of the other problems that I deal with on a daily basis.
Yeah, I think it's fair to say most viewers, the host included, would not have made that connection.
That's kind of what I work with every day. So, yeah.
Interesting. Yeah, well, keep going. You've got some great examples.
So let's kind of go through this. So I put up a lot of information on these slides about history and things like that because there's been so much speculation. Well, this tongue tie thing's brand new. All right. This wasn't a thing
Not
many
exactly.
years ago. Okay. This is an obvious picture from 1679 of somebody doing a tongue tie.
Wow.
Okay. So this has been a problem for a long, long time. I frankly don't know why it's getting worse. I'm guessing it has a lot to do with epigenetics. I'm guessing it has a lot to do with the way we eat, what we eat, how we eat, and all the other factors that that we're dealing with from environmental toxins and everything like that.
Sure.
Okay. But there's no right answer for that question.
But to your point, this is not a new thing. We didn't just make this up last year.
No, we absolutely did not. No. So I have a lot of research and things like that. But the incidence rates, they say it's somewhere from 3 to 13% of the population end up with something like this. And 100% of the ones that come in to see me are, you know. Now that said, I actually turn some patients away where I say this isn't the problem and I can't fix this. But
yeah.
I thankfully, and you're the same way, have developed a pretty good network of people to send to. All right, whether it be chiropractor, craniosacral, massage therapist, and things like that.
Right.
And there's some here in town that will work on infants. All right, which isn't easy, but they do a wonderful job.
Right.
You know, so. If I'm not going to do it, I'm going to send you to a person that does.
But maybe another way to say that, I think, correct me if I'm wrong, is, sort of all problems breastfeeding are not related to tongue ties.
No.
There could be all kinds of jaw problems, craniofacial, birth trauma things with torticollis and all of those.
Absolutely.
That you're not going to be able to fix, but yet it doesn't mean it's not a problem.
Yeah.
It just means it's not a tethered tongue at the root of the cause.
Yeah.
Okay.
Yeah, and that's why I try when I do my evaluations to pick up on some of those other things.
Yeah.
If you have a little baby who's just stuck like this, I can't really get them unstuck. All right, that's where a craniosacral therapist or a chiropractor, that's what they do. Okay, I'm not doing those kind of things at this point in time. Now we do have some other kind of lasers that I use, and we'll talk a little bit about it that help with some of that stuff.
Sure.
But by no means is that my scope of things. So. So why do we treat infants? All right, and we were talking a little bit about this. It's not just what it looks like. It's not just the mom that's having the trouble. A lot of times it's not the mom. It's a lot of times the infant themselves.
Yeah, that list is impressive.
Yeah. So we just gotta. All I'm trying to do when I do this is just get function back to normal. All right. I just want this little baby to be able to do what they were designed to do by God. All right. And it stinks that I have to go in there and do something to help them, but the results are great, so they don't like it, but the results are good. Just a little bit more stuff. So I want to kind of walk you guys through how I actually evaluate these cases, okay? And we've kind of touched on it a little bit. I do a pretty thorough medical history on every one of these, including some of the mom, all right, including the birth story and everything like that, okay? And then when the mom and dad come in, all right, my hygienist or my myofunctional therapist, Jill, she works with me on all of these cases. She gets the rundown, all right? And then she kind of fills me in, and then I'll come in and do the actual exam, okay? When I'm doing this exam, it actually does not start with me looking at the baby. Actually, it usually depends on how mad the baby is at that point in time. If they're already mad, I'll just go in and do it. If not, I start asking the mom and dad, how's it going? What are you noticing and things like that. And you saw all of those issues I put up just a minute ago. They almost all have 1, 2, or 3 of those things going on, okay? And then I sit down with the mom, and usually it's the mom, and we go knee to knee, and I put a little thing on our laps, and I'll show it to you guys here in just a moment. And the baby lays down with its head right towards my hands, all right? I use a bright little light over my head and things like that. And I look at it with the parents. I pull up on the gums, I pull up on the tongue, I feel the cheeks to keep that tension in there, and I show it to them. And then I go through and I tell them, okay, this is what I'm looking for. You can really get lost in those weeds of, is it a class 4? Is it a class 2? Is it class 1?
Right.
And I tell parents, it doesn't matter. It matters, are you having trouble? And is there a functional problem that I can feel? Okay. And if there is, then we need to do something about it. If there's not, that's okay. I'll tell you who to go to.
Right.
No.
Nice.
So it's
And then how long does that evaluation take?
everybody's a little different, as you know. But usually you're talking about a half hour.
Sure.
All right. And then when it comes to trying to help these moms, I always block my schedule to be able to do it same day.
I see.
All right.
So you'll find it, evaluate it, treat it right there in the same spot.
Yeah,
Okay.
because I was there with my wife and getting out of the house with a freshborn, with a wife that either had a C-section, vaginal birth. It doesn't really matter. They're not moving as well as they could be. So if they're going to get out, they're going to go, and I'm just going to get it done for them. Okay. But yes, I don't want to challenge the mom any more than she's already being challenged at that point in time.
Yeah, and then I would imagine most young moms don't think about their first big outing after the baby's born to the pediatric dentist office. That's not what they're thinking.
No.
So that is nice that you could get it all done at one time.
Funny story, a little anecdote. I actually had my one of my employees at my dental practice. She was having her first baby, and she tried to schedule the appointment before the baby got there. I was like, well, let's just see if they have one before I actually schedule this to you. So my staff knows what they're doing and looking for and things like that.
Nice.
But yeah, it's so here's what it actually looks like. So when I do these procedures, all right, as you guys can see, I put the baby in a little swaddle. Actually, Jill does all this kind of stuff for me. Okay. I use a little bit of topical anesthetic on the lip and on the tongue. Truthfully, it's very rare for me to do one and not the other. All right. Mainly
You mean tongue
and lip.
Sure.
Mainly because this is trauma. All right. And I would not like to have to go back and do it again at another time if we didn't get the results.
Yeah.
So if I'm on the fence at all about it, I'm just going to say, let's just do both of them. The healing time is the same for both of them, and we'll go from there. But you can see I have a little laser there on the right, and Jill actually holds all of the babies while I do it. All right? One of the things that I just couldn't wrap my head around is strapping the baby down. All right. I didn't like it when I saw my kids have it done. So I'm like, I'm not going to do that. Thankfully, Jill is incredibly strong and she can hold them very well.
And the swaddle seems to help.
And the swaddle seems to help. We had a little 5-day-old one who was sneaking out of it the other day. But it's quick. You're talking the amount of time I'm actually in there cutting, 10, 15 seconds.
Nice.
Okay. And then I'm just trying to stretch that tissue until if anybody's ever done one of these, you'll know. All right, you'll feel it release. Okay. Oh, okay, there it is. Now that tension that you're pushing on is gone.
Nice.
So it goes pretty quick. Baby doesn't love it. All right, but I kind of inform parents of what they're getting themselves into. So typically in these kind of cases, this room is right next door to the room that the parents are in. All right. So thin wall, they can hear it all, but I want them to be there. All right. And now if they can't handle it, they go to the waiting room, and that's just fine. But I want them to know that I'm taking care of their baby.
Right.
All right. Whether they like it or not, I'm taking care of them. So this is kind of what it looks like. So this is before.
That's a great picture.
It's a good one. Yeah. The afters are not nearly as good for some reason, right? Yeah.
But that shows that tether in the middle.
Exactly.
That classic anterior.
Yeah. Well, so this is a classic anterior, but can you see how the middle of the tongue doesn't move at all?
Yeah.
All right. So this is one of those that there's so much tension. And you can see my fingers here. I'm actually pushing on that tongue. All right.
And that's all you're getting.
That's all I'm getting. Yeah. So this little baby just cannot move their tongue up. All right. So they cannot compress the nipple or the bottle. So basically they're just gnawing on everything. Okay. And then I'll show the lip. So there's a pretty classic. You see the little lip right in there. Again, they get a little madder the longer I try to take these photos and things like that. All right. So this lip tie actually isn't too terrible. All right. You can see it just a little bit of blanching, which is whiteness of the tissue in there. Not terrible, but bad enough. And with the mom saying, yeah, it never curls up. It never releases up, that we're just going to do both of them.
Sure.
Okay. That's what it looks like afterwards. All right. So it makes this almost every time this little diamond shape.
Yeah.
Okay. And usually there's actually not that much bleeding. Okay. The CO2 laser that I use is really good at hydrolyzing the tissue in there, or it's not cautery, but it's basically getting rid of the moisture in there. All right. So you really don't get a ton of bleeding. And I don't cut very deep. All right. When you start cutting, shockingly, things bleed a little bit more. Okay. And then that's what the lip looks like. So the lip, again, is a functional thing. So I cut, and then I kind of see how far I can pull it up. And you'll see it'll go all the way up into that vestibule up there, and then you're good.
Yeah.
All right. So this is our 1 week follow-up. So every mom and dad that comes in to see me, it's mandatory that they come back the next week. All right. I want to make sure things are healing well.
Sure.
Okay. And I like to explain to them what the expectations are moving forward. All right. Because the best surgery in the world, this thing is no different than if you cut your arm. That tissue is going to tighten back up. All right. And then it's going to release again. And it's about a 6-month process. All right. To get there. So I've had some moms and dads come back at like the 2 months, like, it's back. What are we going to do? I'm like, well, that's the natural healing process.
Yeah.
Because you can't actually get that tissue to go away. You don't really want it to. It'll reattach in there. You just want enough tension release that the function can go back to what it needs to be.
Sure.
But the 1 week follow-ups are great. Truthfully, moms and babies are always doing really, really well.
Nice.
So a couple before and afters. So that one's a little bit more. You can see
that's a better picture.
That's a good one right there. So on the left there, that's a lip tie. And you can see how that alveolar ridge or that bone right up there goes in right there. That's that tie going all the way under and pulling up on everything. So this little one, there's no way. And then that's another one of those glaringly obvious kind of class 4s right there. And then that's what it looks like after. All right.
Nice.
Another before. Some of our pictures are better than others. It's kind of hard to take pictures of little babies.
Yeah.
This is the during, and then the after. So stretching. All right. This is
to your earlier comment. This is probably as important as the device.
Way more important than any of this. So it's not hard. All right. We're not asking moms and dads to do a ton of things or anything like that. I remember doing this and be like, oh my goodness, I feel like I'm killing my child. All right. They typically hate it for the first 2 weeks, and then they don't care anymore. All right. But really all we're trying to do is keep that tissue from attaching really quickly. Okay. Especially the lip. The lip attaches really, really fast because it doesn't have a lot of movement. All right. So, and really what we're trying to do is just some gentle sweeps and some pushes and things like that. 5 seconds. Okay. Yeah. It's not a lot. It's just you have to do it several times throughout the day. And I make you do it for 6 weeks.
Yeah.
Okay.
Whenever I hear you say that, I think of the analogy. If anyone's ever bitten their lip, it hurts and it's a defect that you can feel. It's often gone by the next morning.
Yeah.
That's how fast that tissue grows and heals. So you have to do this.
Yeah.
Or by a day or two later, your work it's gone.
Done. Yeah. And this has happened a few times, where, and for whatever reason, mom and dad, another kid was having trouble and they couldn't do it. And that's fine. I'm always there to help. Okay. But some of the time when I see them at that week follow-up, mom and dad have been a little struggling, and it's okay. I'll have to re-stretch the tissue.
Yeah.
All right. So I'll go in and I'll actually pull it back open. All right. And the baby doesn't love that, but it's better than me cutting it.
It's 6 times a day for 6 weeks. So that's a lot. Yeah.
So I tell parents, like, the best way to do it is when you're changing the diaper, so you're just going in, changing the diaper, or beforehand, you're just putting your finger up there and kind of rubbing across and pushing just a little bit, and you're done, so.
What about the tongue? So that would be the lip.
Same concept.
Same idea.
Yeah. So you're kind of getting underneath the tongue and then pushing up is what you're trying to do.
Yeah.
Okay. Just trying to keep that tissue moving.
Yeah.
All right. Because like you said, the mouth, and anybody that's ever gotten a pizza burn on the roof of their mouth, it's terrible, but it's gone in like a day or two.
Fast.
So the mouth turns over, especially in these infants. It's really, really quick.
Okay.
So nope, it's mandatory. The good news is we do 3 things for every parent that comes in there. We show them a video on how to do it. We demonstrate it live for them, and we give them a paper on how to do it. All right. And our paper also involves aftercare and things like that, to try to get them feeling comfortable. And it's really not too hard. Usually it's just breastfeeding, or bottle feeding or whatever you need to do there.
Right.
So, yeah. But yeah, moms feel a lot better. Yeah. So the scar back down part of this, those stretches, those are important. Yeah. So I think this is actually a video on reel. I don't know if you would you like to watch it?
Oh yeah, sure.
Yeah. So this is live, or what it actually looks like. All right. So I use those funny little rabbit ears. Okay. And this is truly about the amount of time it actually takes to do all of this. Baby's obviously not a big fan or anything like that.
But that was it. It's
That was
done.
it. That's
Yeah.
it. And
It's
it's
a
done.
firing and it's over. Yeah.
Yeah.
And it's probably fair to point out to the astute viewer that that's not smoke coming out. It's
No,
water vapor.
It's water vapor.
Yeah, it looks
yes.
like smoke, but the CO2 laser turns
Yep.
water-based tissue to vapor.
Exactly. Yeah. And no, that would be very terrifying. Smoke coming out. No.
But it does look like smoke. But
It
it's not.
does. No. So that was truly live. I mean, obviously we cut a little bit in the middle as we transition from one side to the other, but
But really fast.
really, really fast. This is an interesting part of what we try to do. So this is called a Fatana laser. All right. There's this whole academy called the Synergy Academy that does something called myolase, babylase, and oralase. All right, using lasers that don't cut to release tissue and trauma and things like that. So before I ever go in and do any cutting, Jill actually will go in and use this laser, and she'll work on those buccal ties that you've heard about, all right? And she can get them to release just by using the laser.
Wow.
All right? And then she'll go under the tongue, and she'll do the lip just to try to get that tissue moving a little bit more. We also use this quite a bit on patients that come in who have had a tongue tie within the last 6 months, and I can't really do another one, all right, until that healing process is over with, or I just create more scar tissue.
Oh, sure. So that may soften the tissue.
It'll soften the tissue. It actually works by breaking up, I believe, the hyaluronic acid that's in the tissue, and it's kind of crazy. So Jill will do this, and you'll take, let's say, a 10 millimeter space, and it'll go to 15. All right, you can just get that much release just doing this with this laser. The other really cool thing about this is with these little babies who are kind of in that fight or flight kind of scenario, for whatever reason, you can do this a couple of different pathways throughout the body. You're really working on the radial nerve of the arms and up the toes and up the legs and the vagus nerve, all right? And you can get these little ones to go from a fight or flight into a rest and digest, all right, just by lasering them, okay? Now, I am by no means an expert in any of this. I just think it's pretty cool that it actually works, all right? So she does a ton of that kind of stuff, and it can't hurt the baby. It's just helping them,
Yeah,
you know?
great.
So it's definitely unique, and there aren't very many people that do it. But we are getting a lot of lactation consultants sending us patients for those buccal ties, all right, where their cheeks are just rock solid in there. And that usually kind of creates a pulling pattern across the front, and they just can't get the lip moving the way they want to.
Right.
So instead of cutting, which I have no research to say I should cut those, we'll do this.
To soften.
And it works.
Interesting. Wow.
So, yeah, it's definitely different. So I don't know if you want to transition into this kind of stuff, but I like to talk about what this becomes, all right? Because so many parents that come to see me start talking, well, wait a second, what about my other kid? You know, I had one family come in the other day, and she brought 2 of her other kids. She's like, well, do they have them too? And I was like, well, lift your tongue up, let me see. Like, yeah, they have them. What other symptoms do they have? They have all the classic symptoms and things like that too. So typically,
what is the connection, the bridge, so to speak, from that to
yeah.
pediatric sleep problems?
So it's function. So when the tongue, let's say that nobody ever did anything with it when they were a kid or anything like that. So it's kind of always tied down, okay? It almost always creates an obligate mouth breather, all right? Because that tongue sits in the floor of the mouth, okay? And your body will pick path of least resistance. And in that scenario, it's always going to be the mouth, okay? Right. So I can use myself as a perfect example. I have a tongue tie, all right? And I didn't know any of this until I started doing this kind of stuff. But what happens is as that tongue sits down, all right, your maxilla, the top part of your jaw right here, gets more and more and more narrow, okay? And as that gets narrow, actually, the inside of your nose gets more and more narrow, all right? And that's actually what causes a lot of deviated septums, okay?
Interesting.
Because as the roof of the mouth kind of goes from what it should be flat, up, it pushes the septum out to the side, okay? Because what the tongue is really supposed to be doing in conjunction with eating and all of those kind of things is actually supposed to be suction to the roof of the mouth, pushing everything apart and pushing the maxilla forward to create a giant airway so that, truthfully, they don't end up with sleep apnea or TMJ issues or things like that.
Wow.
Now, how it correlates to pediatrics is sleep issues in pediatrics looks differently than in adults. All right. So with pediatrics, typically sleep deprivation is what we're really talking about. And really, we're just talking about mouth breathing. We weren't designed to breathe through our mouths. We were designed to breathe through our nose. So when we breathe through our mouths, we actually suck in too much oxygen and we blow off too much carbon dioxide, all right, which really messes with the acid-base chemistry throughout your body. Then your O2 saturation starts to dip as you go through that, okay? Adults end up with sleep apnea where they're gasping for air. Kids can get that as well. It's not usually as obvious. Usually in kids, you're going to see something like you can hear them breathing at nighttime, all right? Or they look chronically fatigued. Their eyes are all swollen and things like that. When you talk about symptoms of it, all right, they almost mimic ADHD. Okay, so ADHD and sleep deprivation in kids is identical. All right, so you get hyper. You know this about all of your kids and your grandkids. When they don't sleep, they don't get more tired. They get hyper.
Yeah,
all right,
it's not good.
Adults get tired. Kids get hyper.
Yeah.
All right, so with this kind of thing, what we're really trying to do is just get the function right. And in kids, if you catch them early enough, they can correct all of this just with muscle function.
Wow.
All right, so just literally getting them to sleep with their mouth shut, breathing through their nose with their tongue up, all right? And then the chances of them needing me as an adult to do TMJ treatment and sleep apnea go way down.
Wow.
So
something that simple. But I mean, I guess it makes sense as you're connecting all those dots, but tongue function relates to sort of jaw development and mouth and nose and airway development. So if one's dysfunctional, the other one's not going to work either.
Yeah. And one of the big signs that we treat a lot when it comes to kids is like, bedwetting. All right. So that's the night terrors, nightmares, and things like that. Those are almost always on kids that struggle to breathe through their nose.
Oh, sure.
All right. So when you have these breathing problems at nighttime, all right, so adults, they gag, they have that obvious snoring like a freight train and things like that. Well, kids don't tend to get that. But when you get this O2 drop throughout the night, your body goes into that fight or flight response. And then you'll get kids coming in your room, I'm having terrible nightmares, all right? Their cortisol level spiked while they were sleeping, okay? Because their body thought they were dying, okay? Or the really interesting one that I love to tell people about is the bedwetting thing. Because how in the world is bedwetting
Related to your tongue.
Related to your tongue. So what happens is as that airway, as you breathe through your mouth, your O2 saturation goes down, your body thinks you're suffocating, so it starts to create a bunch of red blood cells, all right? Because that transports oxygen to your muscles, okay? So it starts creating them. They go from your legs up to your chest, into your heart, all right? And they pool in there waiting for that oxygen. Well, there's no oxygen because you're not breathing the way you're supposed to. So then your body sends a hormone to your bladder to tell you to go to the bathroom, all right? So kids, they just wet the bed, all right? Adults wake up 3 times to go to the bathroom, and they just think that's normal, okay? The coolest thing about kids is if you can actually get them to sleep with their mouth shut, with their tongue up through their nose, they will stop almost instantly, all right? So we had an example. I had a 9-year-old that was doing this and had been doing it for 9 odd years, okay? Within 1 week, he stopped, all right? Just by getting him to keep his mouth shut while he was sleeping, So
now,
it's
other
just
than saying, hey, shut your mouth, which that's another parenting thing, but
it doesn't work.
how do you get a child that age to sleep with their mouth closed?
Yeah, so we have some appliances we use called the MyoBrace system, all right, which is something that goes in the mouth and it positions the tongue where we want it to go. And then, lip taping is another one when they get to that point. You're literally like putting a little piece of tape over their lips, just try to keep them
to hold it
closed.
together.
Okay. Now, not duct tape, all right? Everybody thinks that's a thing. No, we're just enough to slightly keep them closed. With them still, if they need to, they can tear it off, okay? But truthfully, one of the biggest things that we run into is allergy issues or nasal congestion issues and things like that. So we do what we can in the dental world to try to help with it, nasal sprays, nasal rinses, all right? I try to send patients for like simple allergy testing and things like that too. But yeah, if the long answer to all this is if you can get kids to function normally, they're going to do great.
Wow.
All right. And that's really what, from the infant tongue ties up until, the 12-year-olds and things like that we work with, is just get them to be how God made them.
Wow. I mean, it is hard to think that we've gone from finding a tongue tie with a breastfeeding problem to bedwetting.
Yeah.
But the connections are obvious the way that you described them. That's pretty fascinating stuff.
Yeah, it's and you know this about the body. The body's connected. Us on the medical and the dental field. I like dentists. We do teeth. All right, we don't do any of that other stuff.
Yeah.
You work with
Other
birth
parts.
and things like that. We're not going to talk about the other parts, but we just compartmentalize it all, and it's all connected. That's how God made us. We're connected beings.
So, I mean, I just can't escape what probably is the obvious question, at least it is to me. So, I mean, everything you've said to me sounds brilliant, and we've certainly sent a lot of patients to you that come away happy.
Yeah.
I mean, I guess we just have to try to dig into the dirty little secret. Why is this such a problem? I've had lactation consultants tell me they whisper to patients in the hospital, I think your baby has a tongue tie. Please don't tell anybody I said that, but go call this dentist, light.
I get a lot of that.
Why do you think, given all that you've done, why do you think we struggle as a profession so much? And I'm thinking of my dear colleagues in pediatrics for the most part.
Yeah.
Why is it such a taboo topic?
Well, I've actually spoken to a couple of pediatricians about this, and the general consensus is, well, we weren't taught it, so we don't know.
Yeah.
All right, so we're not going to suggest something that we don't know
Not comfortable
about,
with.
Okay, and it's not their fault. I can't imagine pediatricians are really taught to examine this. I'm a dentist. I look in people's mouths every single day. I can tell you what normal is, and I can tell you what's not normal.
Yeah.
Pediatricians can do that with every other part of the body, but they weren't really trained for the mouth.
I know what you mean by that. I wasn't taught this. I mean, and I think that might be hard for non-medical viewers to appreciate, but there is this, I'd call it cultural thing with we physician types where, from the day you start medical school, you don't want to be an outlier. You want to be in the middle of the bell-shaped curve.
Yeah.
And if the guy next to you is not talking about tongue and lip tie, that means you're not in the middle of the curve, and that's where you want to be.
Yeah.
And I'm not sure we know we're doing that when we do it, but that is a common psyche, I think.
Yeah.
The other thing that I've heard said, and I hear this about a lot of the areas that we work in, is, well, there's no scientific literature to support it. So, the old, the absence of evidence isn't evidence of absence phenomenon. But that's a common thing. And whenever I hear that, I immediately think about the thousands of things we do in medicine for which there is absolutely no scientific support.
Absolutely.
Sometimes there's scientific support for not doing it, and yet we still do it because of culture. But it really can be a cultural challenge.
Yeah, and I would challenge a little bit on the research. There's a lot of research, and if anybody
That's a
ever
great
wants
point.
it, I have tons and tons of articles about this. Like I mentioned it earlier, that Dr. Zaghi out of Stanford, he's a research guru. He's putting together data all the time on this kind of stuff. But it did start anecdotal, okay? And like you said, medicine, a lot of it is anecdotal,
At least in the early phases. That's right.
There was something I read, and I cannot tell you who said this, but it was something like 50% of what you learn in medicine will change within 5 years, So
If that long.
If that long, yeah. So it's just, you don't know what you don't know, all right? And I don't think very many pediatricians in general are comfortable trying to even fix it, So there was another problem that I think I saw where not every dentist treats this the same way, all right?
That's a
and
good
outcomes can change depending on how you do it. So I mentioned it earlier. I make everybody do these stretches, okay? If you don't have any of that kind of follow-up, the outcomes get worse. They absolutely do. So that's why I tried to standardize as much as I possibly could to get the best probability of outcomes, okay? Also, we mentioned a little earlier, the deeper you cut does not mean better.
Right, more is not better.
No, so I've seen some just horrifying videos of just almost bifurcating the tongue, cutting it in half and things like that. And I think, and I'd probably be the same way if you have one patient that came back with a horrible story, something like that, you're going to be a lot more reluctant to suggest that to anybody else.
Right.
So yeah, it's hard. You got to be a little bit more open-minded and, be willing to talk to other specialties and things like that.
I think the thing that's so hard for a lot of us to cope with is the frustration and the desperation in the mom. She's saying, I don't understand.
Yeah.
I looked online and it looks like that's what my kid has. And I mentioned to my pediatrician and they said it's not a thing. And yet she can't latch and the baby's not doing well. But she doesn't know what to do. If she doesn't just bump into you or someone like you, she feels alone and isolated and it hopeless, which is a terrible place to be when you've got all the other stuff going on with a newborn.
Yeah.
That's hard to listen to and not want to get involved and try to help.
No, and it is hard. And I think one of the things that, and this is past my generation, you may be able to talk a little bit more about this, but I was listening to some podcasts about, the history of all this kind of stuff, and how big the push was, maybe in the 50s or the 60s, to go just bottle feed everybody.
Oh, sure.
And pacifiers in every kid, that kind of thing. And now we know, well, breastfeeding and using breast milk and things like that is really actually good for them, and it actually forms the mouth. And quick little fun history lesson for you on this kind of stuff. So have you ever heard a gentleman by the name of Weston Price?
It sounds familiar.
So he's a dentist that did a ton of research into different tribes in Africa and what their faces look like and things like that. All right. So he postulated, and Dr. Kevin Boyd, he's a pediatrician out of Chicago. He does a lot of this stuff too. Shockingly, he's a pediatrician or a pediatric dentist and a trained anthropologist. All right. So yeah,
Odd
I don't know how
combination.
those went together. But let's go back to the first cavities. Okay. So again, I'm a dentist. So the first cavities, you're talking somewhere in the 10,000 years ago when you look at the record of skulls. Okay. Up until about 300 some odd years ago, almost every single person had enough room for all 32 of their teeth, wisdom teeth and everything. Okay. Then right around the Industrial Revolution, all right, is when everybody started to get smaller and smaller and smaller mouths. Okay. And he kind of put it together that before the Industrial Revolution, on average, mothers would breastfeed for like 3 years. Okay. Which modern, that's crazy. I know.
Right.
The moms that go the longest, you're talking maybe 18 months. And even then,
And that's an
it's
outlier.
incredible.
Yeah.
But the reason I bring that up is because the actual function of breastfeeding, all right, forms the mouth, okay, because it creates the function that you want, okay? Same thing with bottle feeding and things like that. But that's when this all started to happen. Now, none of us have room for all 32 teeth. All of our faces are really compressed in and really small and things like that. And then we eat a ton of junk, so that doesn't help any of it either.
But you remind me saying that about the breastfeeding. I mean, some of the biggest challenges to breastfeeding now are gone because those challenges were cultural. And in many ways, addressing tongue and lip tie problems, it's a cultural problem. We know what to do. It can be done. It isn't terribly complicated to do. But the biggest barrier is just getting past the culture.
Yeah. And can you figure that out for me? I'd appreciate
Yeah, I'll get back to another episode.
Yeah. How do we get everybody to believe what we're saying?
How do we solve human nature problems?
Exactly.
That's probably another episode.
Yes, I think so.
That's really fascinating. I mean, so I guess from a really practical standpoint, how does a frustrated mom or other provider that has a frustrated mom, how do they get in touch with you or someone like you?
Yeah, so it's there aren't very many in town. All right,
In our Fort Wayne area.
In our Fort Wayne area.
Yeah.
There's maybe 2 or 3 of us, and you probably know all of them anyways.
But is there a way in our community and well beyond our community to find someone like you? How do they know they're talking to someone like you?
Yeah, so there's a bunch of Facebook groups. All right, I'm not big into social media. It's just not a part of my life.
Sure, that's probably a good thing.
It's probably a good thing. I just don't. I know it's important, especially if I want to put myself out there and things like that. But there are some wonderful Facebook groups for moms searching for this kind of stuff.
Who would direct them to people they've had an experience with.
Exactly, yeah. And I know because some of my staff has checked. My name comes up on those quite a bit, all right? But typically when I talk to patients about what to look for in this kind of thing, look for airway and function, all right? Airway and function.
Those key phrases.
Those are the things that you're really looking for, all right? Because those are the people that are going to think more whole health than they are cut.
More of an integrated, it's not just the tongue, it's all of the other parts of the anatomy.
Yeah, it's the tongue, and then this is why it's the tongue and how this all correlates to what your child may have in the future and things like that. But it's been difficult. That's why I've been trying to do this kind of stuff. So personally, I try to get into dental offices. I've tried at like Parkview and they don't have as much time, all right, but I'll do lunch and learns for anybody that wants to listen to me. But it's challenging, and we talked off mic a little while ago. There was a really bad article a couple of years ago that really, I don't know if it hurt the field because everybody in the field was like that was nonsense, but moms that read it, they might have been a little unsure at that point in time. And the gist of the article was this is being done too much and it's not necessary. Okay. And if you really dive down in the article, that wasn't actually the conclusion of the article, but that's kind of what the headlines were.
Sure.
Okay. And they were referencing some dentist, I think, out of New York, who had been doing thousands and thousands of these things. All right, and he had one or two bad outcomes. All right, and that's medicine. It doesn't happen very often, but a bad outcome is okay as long as the provider is willing to help you through it. And that's what I would do. I hope I never have any bad outcomes.
Sure.
But
But
it's
we
medicine.
will.
Yeah, but I can't control all the variables. But yeah, that was an article, and I think it was in the New York Times or something like that.
Speaking of sort of social media, I've seen maybe recently more than before in the dentistry area, sort of influencer type saying, and it happens in my specialty as well. If your doctor recommends this, don't do that. Insist on this instead.
Yeah.
And with the implication is always, this is profitable. That's why they want to do it. So don't do that.
Mm-hmm.
I'm sure you've experienced some of that sort of kind of hating kind of talk.
Yeah.
But we're talking about changing kids and moms' lives here.
Yeah. Well, and your point there is like I'm never going to tell somebody you have to do something. And I try to get the mom to be their own advocate. It's like. I look at them like, something's wrong here.
You wouldn't be sitting there.
Yeah, you wouldn't be sitting there. And, other people have told you it's not wrong, but you trust your gut. Mom's guts are amazing, all right? They know if something's not right, okay? That's why God made them that way, So I try to get moms to do that, and then I help them through it, and I'm a dentist. I can work from here up, So I do what I can in that space, but it's challenging.
Do you find yourself talking to newer dentists right out of dental school and trying to influence them? Hey, you should think about this.
I've never been that pushy about that kind of stuff. All right, I just don't feel that comfortable doing it. I like to talk to people that are interested, because trying to push, and if anybody's ever gone into the functional, holistic, biological realm, trying to push into somebody that's not interested, it ain't gonna happen.
It's not a good conversation.
It's beating your head against the wall. So I even do this in my practice. Like if somebody wants to talk about it, absolutely, I'll talk about it with them all day.
Yeah.
But if it's not for them, that's okay.
Yeah.
All right. There are other ways to get to the end.
You could sort of imagine this perfect world one day where, all sort of birth and child providers of whatever specialty and flavor they are would be sensitive to recognizing anatomical problems like this.
Yeah.
And if they don't repair them themselves, have a network of people in multiple communities they could easily refer to.
Yeah. And that's what I'm trying to do, at least in Fort Wayne, So I'm getting a bigger and bigger network of providers that will work with babies, okay? From craniosacral therapy to physical therapy to chiropractic care, to massage therapy to lactation and things like that. Because I want to be able to help the moms if I can't do it, So, can you figure out that perfect world for us someday? Yeah.
Well, there's a lot more imperfections than those that we listed.
Yes, yeah, absolutely.
Well, that's fascinating stuff. Thank you. Well, thanks for your work, for one, and thanks for your willingness to sort of step out there in a realm that sometimes is uncomfortable. We share some of that space sometimes.
Yeah.
But thank you for the work that you do. I know that you're helping a lot of moms and a lot of babies.
Yeah.
So thank you for being willing to do that.
No, I appreciate what you do. And I said this to you earlier, but you guys helped with our first baby, and our second was number 26 at the birth center here. All right. So we signed up even before it was open.
That's outstanding.
Like that. But no, so last little thing I wanted to kind of tell you is when it comes to what I do for a living, okay, I do a lot of infants. I work with a lot of kids and things like that. But I just briefly mentioned a few things that what this becomes for adults. Right. Because, that's where it gets a little bit more nebulous.
That's not as intuitive, is it?
No. So it starts with a function problem, all right? And in general, gross generalizations here, all right? If that function never gets corrected, okay, men tend to end up with sleep apnea.
Okay.
All right? Women tend to end up with facial pain, TMJ, and headaches and things like that.
Wow.
Okay? It has to do with the hormones in your body, why one does and one doesn't. But that's usually how that goes. And typically for women, it'll show up something like struggle to fall asleep, wake up 4 or 5 times a night. When they wake up, they're wide awake, all right? And then fatigued in the morning and everything hurts, okay? Men, they don't have any of those problems. They sleep through the night, they snore like a freight train, and they stop breathing 50 times. So that's typically what that becomes.
Wait a second. Stop the tape, I guess, because it almost sounded like for a second there that you're suggesting that men and women are different.
Shocking.
We
right?
could get canceled.
Yes, absolutely. I always like to use the phrase when I tell patients this. I say, women obviously smarter than men because instead of dying, they wake up. All right, men just die right through it.
Wow.
So,
Thank goodness.
but yeah, so just for you parents out there, that's typically what this will become. If you don't do anything about it. And the longer you wait to do something about this, the harder it becomes to fix it.
I mean, that's a great extension of maybe your bottle feeding, and there's obviously no latch issue. But that doesn't mean you're out of trouble. There could be much later, far-reaching ramifications into adulthood.
Yeah. Wow. One last plug for us dentists. All right. Pacifiers in general. All right. Okay. Just so you all know,
We've gone from one controversial topic to another. Excellent.
Not all pacifiers are created equal. The pacifiers that I like from a functional standpoint for little ones are ones that take effort to keep in their mouth. All right. So
that's interesting.
Probably the best one is called the ninny. All right. It's actually shaped like a breast. Okay. But it takes effort for the baby to keep it in.
Meaning it'll fall out without
them creating that suction habit. So a lot of them are actually made to stay in there without it. Okay. Yeah. And it always creates a vaulted palate, and it always creates low resting tongue posture, and then that's where the rest of this stuff goes. So I am not sponsored by Ninny or anything like that, but I give them out in my practice.
I certainly encounter strongly held opinions about pacifiers on an hourly basis, as I'm sure you do. But
yes.
And I'll have to admit, if I think purely breastfeeding, I'm not sure why it would be a problem because nothing's coming out of the pacifier. Now, I have seen many, many times moms trying to bounce back and forth between breast and bottle, especially in a very young child. They figure out it's easier to get the milk out of the bottle. It just falls in.
Yeah.
But when the pacifier, nothing's coming out, I would think that isn't going to create a feeding issue.
Yeah.
But speak a little bit more. There is the potential for it to cause the structural kind of problem.
Yeah. So I see this all the time in general practice for dentistry, and any parent that's ever had somebody that used a pacifier like past 2 years, their front teeth are always kind of curled in. All right, they're really, really narrow on the top. Okay, so I'm not against pacifiers. I get it. I have 3 kids, and they all used a pacifier. All right, but no, I truthfully like the pacifiers that create muscle tone. All right, and many of them do not.
Interesting.
They're meant to help keep the baby as quiet as possible and soothe them. That's actually not good for them, all right, because it'll create these tiny little mouths, all right, that have these issues moving forward.
That's interesting.
Yeah.
Well, while we're on that, you remind me, what about thumb sucking and its effects on the mouth? And
that's the hardest one because you can't cut the thumb off, So it almost always does the exact same thing because every kid that thumb sucks, they're going to put the thumb to the roof of their mouth and they're going to pull it forward, all right? So it collapses the sides just like anything else and pulls those front teeth forward and creates an open bite. So what happens is the mandible actually stays retruded, okay, it stays back, and the maxilla gets pulled forward. Well, just so you know, where sleep apnea happens in general is right there, all right? So if that mandible's always pulled back and the tongue's down, that's a recipe for sleep apnea.
I mean, so as a dentist and a parent, how do you speak to thumb sucking?
Yeah.
Because in some kids it's easy, some kids it's a nightmare.
Truthfully, when it comes to thumb sucking, the kid's got to be ready.
Wow.
All right. I mean, we've tried all of the different things, from like putting cayenne pepper on a thumb and things like that. The kid will just figure out how to get it off and then do that. Yeah. So we try to actually supplement them with other oral appliances, all right, that kind of take the place of it.
I see.
Okay, ones that actually create development, and that's back to that kind of myo brace kind of thing.
Right.
Or for the little ones, it's called a myo munchie. It's really just something for them to kind of play with. Where now their thumb can't go in their mouth, and they're getting that oral stimulation.
I see. But for the record, it does change the shape, or has the potential to change the shape of their jaw and teeth.
Yeah, I would say 99.9% of the time it absolutely does. Yeah.
Whenever I see an older child sucking their thumb, I think, you're supporting our colleagues in orthodontia.
Yes.
You've just cost yourself a lot of money to correct all of them. Of course, they can't fix the jaw things. They can fix the cosmetic teeth part. But that jaw structure and function, that's going to be tough.
No, and one thing, I don't really want to demonize thumb suckers because a lot of these kids that do it, they physically cannot stop themselves.
Of course.
Yeah. And yelling at them and telling them it's not going to do anything for them.
Yeah.
like I said, typically the best case is where the kid realizes that, hey, okay, this isn't right, and I need to do something about it.
Interesting.
So we've even tried like taping their arms so they couldn't get to it. They just broke the tape and got right back to it.
Yeah.
So,
But I
yeah,
like that idea. You try to replace it with something that's not damaging.
Yeah.
As a distraction, maybe.
yeah, to try to get that oral fixation. I mean, there's always underlying issues, and they're issues that I can't really fix.
Yeah.
There's almost always some kind of mental cognitive issues going on the other side, or deficiencies or traumas or things like that that are way out of my scope of knowledge.
Yeah.
But they're obvious when you start taking long medical histories on these kids. So
There's something there.
there's something always
Well, big takeaways for our listeners. What are they?
Big takeaways. Well, that's a good question. So, function is probably the most important part of this. All right. And then I tell all of my patients is I'm just trying to get everybody back to the way God made them. All right. And how we're supposed to be is a simple little tagline: tongue up, lips closed, healthy breathing through your nose. Okay. So that's how you were designed to be. We just all are really, really bad at it. So,
Wow.
yeah.
That seems like a good takeaway.
I think it's on our wall at my practice.
Yeah. I just can't get away from, and you've said it several times about God designed us to be, but isn't it fascinating when the natural law and the natural design is off from, in this case, in this discussion, a tongue tie, there's plenty of other examples, everything else gets messed up.
Oh, yeah.
And then it's beautiful how when we restore to that natural state, everything comes back into line.
Yeah.
Yeah, we
absolutely.
go from being broken to unbroken.
Yeah, and it's so cool when things change that people don't even think are going to change, you know, and that's a lot of fun when you start working with the kids. Like, well, he's not nearly as hyper anymore. Oh, he's sleeping through the night now. Like he can focus, his grades got better, you know, so.
All we have to do is get back to the master design.
Yeah, it takes us a long time to get there, and we deviate all of the time.
Don't we?
But, yeah, if only we could do that. Right back to the garden, then we can find.
Well, thanks again for your time with us. I hope we can get you back to talk. Since we covered thumb sucking and all the other big ones, we'll think of something else to cover in a future episode.
Well, thank you for having me. I
Yeah.
really
So,
appreciate it.
and finally, before we leave, patients want to reach you directly. How's the best way to do that?
Yeah, so my website is TMJ and Sleep Therapy Center in Fort Wayne. So that's probably the easiest way.
And if they search your name, Dr. Aaron Light, L-I-G-H-T.
I will come up on there, and I'll come up on Summit Dental Group, which is my general dentistry practice. But if you call there, they'll send you right over to me.
Okay, and providers listening, they think I have a child, I need to get them to see this guy. They just call your office and you'll get them in.
Yep, we'll get them in. Like I said, I especially for the infants, I make time, you know, so it's I've been there, I've done it, and I know how much of an emergency it can be and how quick we want to get this done. So I will always, if I have to go over lunch, things like that, we will make time to get these little ones in.
Wow, excellent.
So.
Well, viewers, I hope you've enjoyed this at least a fraction as much as I've enjoyed listening to Dr. Light. It has really been enlightening, pun intended. I hope you'll join us for other episodes. I'd love to know what you think about this episode. Gently give me some comments, if you would, below. We'd love to have you like and subscribe and share this with absolutely everybody you know. It helps us keep bringing content like this. I'd like to thank our friends at the Holy Family Birth Center, it was referenced a little bit earlier, for providing this studio and producing this podcast. We hope you'll join us again for future episodes. Again, like and subscribe, and let me know what you think and things that you'd like to see addressed in the future. Until then, we'll be back soon with another episode of All Things Women's Health.